ADELA is a trial that explores the synergism between elacestrant and everolimus that we saw in preclinical models. And it makes completely sense because the standard of care in first-line endocrine-sensitive metastatic breast cancer is combination with CDK4/6 inhibitors. So it's in this scenario where the ESR1 mutation appears, and probably up to 40% of patients, the mechanism is related to this ESR1 appearance mechanism. So elacestrant is approved in this particular setting based on the EMERALD. And we have some good data showing that everolimus has a synergistic effect with other endocrine therapy agents for this second line. It's true that we don't have so strong data following CDK4/6 inhibitor, but it's a very good standard of care in many countries as second line, the combination with other endocrine agents. So it makes completely sense to explore if adding everolimus to elacestrant will be able to increase the benefit that we observed in the EMERALD study. As well, the ELEVATE is exploring also this combination is because of this ELEVATE phase 1 study that we got that the combination, the dose for everolimus in this combination was 7.5 and not 10 milligrams. That introduces safety to the combination. So one of the requirements in this study is that patients should be progressing on a CDK4/6 inhibitor for more than 6 months in this first line. It's true that probably the optimal are patients that progress more than 12 months, that are the ones that usually more frequently develop ESR1 as the driver mutation and probably the driver mechanism of resistance. But again, I think that this is a study that involves one of the most interesting strategies, focusing on the only mutation that is related to the treatment itself. Because we have other mutations like P3 kinase mutated, but we have observed in other studies with elacestrant that this drug also works in P3 kinase mutated. So we are not very scared about those patients that could harbor the two mutations that we will study also in the study. Okay, so ADELA will be probably positive, but whatever, ADELA is a win-win study because whatever the combination is for an ESR1 inhibitor. It's true that now we have seen data from SERENA-6 that is monitoring patients in the first line till the appearance of ESR1, but before the development of truly clinical progressive disease. And I think that this is interesting. Not sure that it will be practice changing because finally we are not in a hurry for those patients because at the time of progression we have very good drugs like elacestrant that work very well. So in the monitoring is simple, that's something that we can propose to many patients, but certainly not to all patients will be good candidates. Hyperglycemia with everolimus is not so common than with other inhibitors of the cascade of P3 kinase. But it's true that everolimus has two major toxicity problems. One is stomatitis, and the other is pneumonitis. Obviously, pneumonitis is quite different from the pneumonitis from HER2 or others, and it's a problem that can be detected quite easily. And by stopping treatment, reducing the dose, or giving some corticoids, you can handle that. Stomatitis is a major concern, and it is true that it's extremely important to introduce mouthwashes with corticoids. And that's something that we are per routine doing. It's something very standard since the data that were presented many years ago from the EXPRESS study. But it's important to stress that those patients at many times will also require the combination not just of a physician, but also a nurse to follow the patient and to explain the rules about how to take the drug and how to do these preventive treatments. I think that it's crucial to increase the activity of the second line. So what we know is that standard first line is a combination. So it makes sense that second line should also be a combination for those patients in good condition with, but obviously looking for combinations that are have low toxicity. So quality of life is a major goal. Okay, so probably in the future you will have patients for which you will not want to face too high toxicities, and single agent is fine. Elacestrant has shown amazing results for those patients that were doing well on acidicafo. ESR1 mutated more than 1 year on acidicafo, you can guarantee 7-8 months on elacestrant. But for many patients, you consider that probably you can improve these results by moving to perhaps 20, 15 months of treatment, and this is the kind of combination that we will require, with abemaciclib probably in many countries, with everolimus, and potentially in the future with other inhibitors for dual mutated PI3 kinase and ESR1. So I think that the future for combination in the second line is brilliant.